Chapter 9. Chapter 9 covers the lifespan development and cultural considerations because obviously not all of our patients that we deal with can be pigeonholed into one specific category. A lot of our patients, we have to consider multiple perspectives on their situation. They may be very, very young. They may be very, very old. They may be from a different cultural background, different socioeconomic background, maybe even religion. There's lots of potential items that we may have to take into consideration when it comes to what different angles on their life they may be seeing this on. And so when we look at this chapter, a majority of it will be concentrated on looking at the different age stages that people have in their lives. But we will also touch on a bit some of the different, because of America being the melting pot, some of those different outlooks that we get from people of different backgrounds. Reminder that listening only to this lecture and watching this lecture is no substitute for actually reading and studying your textbook. You're highly encouraged to do both of those. In most cases, it's most helpful to do it prior to viewing the lecture videos. So the standard that we apply here, the AEMT, applies fundamental knowledge of the EMS system, safety and well-being of the AEMT, and the medical, legal, ethical issues to the provision of emergency care. Additionally, the AEMT applies fundamental knowledge of lifespan development to the patient assessment and management scheme. We have just a few objectives for this chapter. Those objectives are found on pages 212 and 213 in your textbook. So an introduction to this chapter. The culture identifies the culture that each person identifies with shapes their different beliefs and values and their expectations of behaviors for others. Culturally, in the United States, we have a very wide perspective. We have those that live in what gets referred to as the Bible Belt down in the South that are very conservative. Here in the Midwest, we tend to be a bit more conservative. However, even the Missouri River has a significant boundary between, say, Nebraska and Iowa, where Nebraska tends to be more conservative and Iowa tends to be a little bit more on the progressive and or liberal side. So with that being said, just locally, we can even see a lot of these things. We see disparities locally, like people who come from a very low, impoverished background, and those who come from a very silver spoon, well-to-do background. We see that often in the same cities. So healthcare providers got to understand that psychosocial development and cultural aspects affect how the patients interpret our actions. And for some cultures, direct eye contact is considered a sign of disrespect. Extending the wrong hand to a person to shake hands is a sign of disrespect. So things that we may take for granted or we may not even think about is something that we need to constantly keep in mind. When you settle into your EMS settings, whether you are going to stay right where you're at while you take this course, or maybe you're going to choose to make a career change or a location change, it's important to understand what cultural aspects affect your community. Here in the Midwest, we tend to have a significant number of Hispanics from the various Latin American countries, obviously Mexico, as well as many of them from South America. So that tends to shape a few of our interactions, as well as a number of African nations, such as crud, totally lost it. Not Ethiopia, but some deep Saharan African countries that we'll see people come over from and settle in our communities to try to start a new life. Previously, we probably saw a few more Eastern Asian countries, immigrants, and so the Laotians, sometimes the Vietnamese were fairly popular. Lincoln, Nebraska still has a fairly high Laotian community. So there's a number of things that as we start to settle in, we need to understand. Now, even those of us who didn't come from the old country or haven't had people who've come from the old country, in generations, we still have some of those things that affect the way we live our lives. Here in the Great Plains, we tend to have a lot of Germanics, people from Germany and the surrounding areas. The Polish tend to be fairly common, as well as the Irish are really some of the more common ethnic groups that settled into the Great Plains. That's not to say we don't ever have any. I mean, we certainly have pockets of large pockets of Scandinavians that had come over to the United States, but in general, we tend to see more of the Germanics, the Irish, that populate our communities. So we have variations amongst people and how that affects their interactions with them, the assessment, and the differential diagnoses process. Now, certainly there are going to be certain ethnic groups that we identify as having higher probabilities for certain illnesses or medical conditions. So, for example, the non-Caucasian ethnic groups tend to have higher probabilities of hypertension, which then leads down the road to higher probabilities of cardiac-related issues. So that kind of goes with the genetics. Not a lot we can say about that. It's not stereotypical. It's scientific. So some of their differences are based off of gender, size, age. Can also be other things. We can say sexual orientation, religion. Sometimes these things all play a big part in how a person lives their lives and the things that they generally see as acceptable. I mean, obviously the Anabaptist religions, such as the Mennonites and the Amish, they're extremely conservative, and in many cases shun a lot of the modern conveniences. And we may have other religions like Christian Scientists. Christian Scientists don't generally accept any medical assistance, and so this can create some definite challenges for our practice. So this Think About It goes back to your case study that you find in the chapter there. So the relationship between the person and their social environment at different points in their life identifies their psychosocial development. So many of us have probably found ourselves transplanted into a completely different lifestyle at one point or another. Maybe we went and lived with a grandparent for a while, or maybe we moved, or maybe our parents suddenly stepped up on the socioeconomic ladder. So those are all cases in which it all affected our psychosocial development. Some of us relate very well to our co-workers and to our patient, while others of us will probably struggle a bit. So a few aspects of things to keep in mind. How is the information perceived? The mental operations performed to make sense of that information, how we communicate with others, and how we decide whether things are right or wrong. So many of these things depend on our our development, how we grew. Did we attend school all the way through? Did we drop out of school at 8th grade? There are a lot of people who didn't go beyond 6th, 7th, 8th grade that still live in our communities. Do we have the ability to make sense of what this other person is saying? Did this other person use a language that's foreign to us? Well, that could be in the truest sense of that, where one person speaks a language and another person speaks another language. Or could be a little bit more of a professionalism thing, or a background thing, where did we speak medicalese to these people and they had no idea what we were talking about? How do we communicate? Do you have the skills to do that? Some of us are not particularly great people persons. Some of us don't do a lot of communication with others when we don't have to. And some of us obviously know that this is something we need to work on. And our perception and our ability to decide between right and wrong, that many times boils down to the way we were raised. So, if your parents taught you to be respectful and not to steal, not to lie, not to cheat, that carries through in many cases. Piaget's theory divides childhood development into really 4 stages based on how that child understands the world. And you can find these on page 214 in your text. We have the sensory motor phase, the pre-operational phase, the concrete operational phase, and then the formal operational phase. And I think this makes a lot of sense, and I think that there's something similar that can be said for any professional development as well. It's a little different in the professional development stage, but to look at it from a child's stance, generally birth to around 2 years of age, they're considered in the sensory motor stage of their development, of their cognitive development, meaning or abilities to think. The infant has limited but developing knowledge and understanding of the world. The primary way of interacting with the world is through its senses and motor skills. Towards the end of the sensory motor period, the use of symbols to communicate or language skills starts to develop. And so I think a lot of us can see that. If you think about kids and how they want to touch everything, they want to taste everything, they're looking at all these colors, and the sights and sounds around them are just amazing, and that gathers the bulk of their attention. Then they move on from around 2 to 7 age group. They're considered pre-operational. So they're now starting to develop their language skills. They're starting to develop a memory, build an imagination, and they start to now put relationships between different items. So relationships between oneself, although they are really more egocentric and don't have a lot of logical thought. So this is a lot of the mind phase. This is mine, this is mine. So I think, when we sit down and put it in a chart like this and start to discuss it, I think a lot of people can go, oh, yeah, I get that. The concrete operational phase then would be from around age 7 to their early adolescence, and this child is now using symbols to think about concrete concepts such as measurement. So we're now being able to say, okay, I get this, but I don't quite yet know how to put it all into one nice package, how to put these thoughts, how to relate all these thoughts together and put them into something complex. And beginning to create this complex thought is the formal operational, starting in adolescence. And many adults don't reach this stage and do not think abstractly about in adulthood. A lot of times people really stick to their very basic thinking. And in EMS, we have to be beyond basic thinking. We have to be creative. And so this formal operational, we're able to start to put things together into a complex message and thought. Now we also have Erikson's theory. And Erikson's theory talks about psychosocial development, where Piaget's was cognitive. Cognitive is the process of thinking, where Erikson's psychosocial is interacting with others, and also has to do with feeling. So Erikson's theory says that it develops throughout their life, and it's shaped by the resolution of basic psychosocial conflicts. And we have conflict throughout our life. We have, even from very early in life, when we're in that mine phase. This is mine. This is mine. I'm not going to share. I'm going to bite you. And those sorts of things. We were constantly in a state of some sort of a conflict that comes up in our life. And sometimes it's not perfectly pigeonholed into some of these approximate age groups that he identifies, but Erikson's 8 stages include, and these are on 215 in your textbook, trust versus mistrust. This is in your early infancy. You're trying to learn to develop bonds and know who they can rely on. And people being overprotective can lead to misplaced trust. In their toddler years, they have this autonomy versus shame. So they're learning the right balance of being self-reliant based off of their parental reactions. So if they're trying to do their things and their parents scold them, that develops that little sense of shame there. They're trying to develop some confidence. Initiative and guilt. So this is the preschool ages. The approval or disapproval of their parents and others gives that individual the ability to take initiative. And sometimes it's a very difficult, I think people get lost there and they lose initiative early in their life. So they're looking for that balance between allowing the child to experiment and do a little trial and error, and letting that child fail from time to time. And that's something that maybe we don't do a great job anymore, is letting people fail. We're in the everybody gets a trophy world now, and there's a lot of good things that can be gained from failing. In industry versus inferiority, which is the school age, that children are allowed to find and develop different talents and hone their skills. They're trying to develop a sense of competence and strength, and if they're denied the opportunity to feel inferior, and they're going to develop some low self-esteem. Identity versus role confusion. This is in the adolescence, really up to the age of around 18 or so, where the child is really starting to develop who they are themselves. So they're trying to no longer have to hang on to mom and dad's coat strings. They want to be their own, or coattails, I should say, apron strings. So they're developing a morality, but yet don't have that experience to lead them to idealism. Young adulthood, so we're in the intimacy versus isolation, so 18 to 40 or so. This is the stage of life where people are looking for their significant other, they're looking to start a family, and sometimes they result in loneliness and isolation because maybe somewhere along the line they didn't fully develop in another category, and it makes it very difficult to get into a truly intimate relationship. Middle adulthood, we have generativity versus stagnation. And this is focusing on successful parenting as a child matures. finding satisfying work, and finding ways to express their creativity. And then finally we have integrity versus despair, which is basically after retirement age, the successful resolution of psychosocial conflicts and feelings of satisfaction and accomplishment in life. So a lot of people say when they get to that retirement age that they would trade it and go back for anything. And then we have yet even another theory. We have Kohlberg's theory of moral development. So this is developing right and wrong. And Kohlberg's theory can be found on page 216 in your textbook, where we talk about level 1 is the pre-conventional morality, and it breaks down into different stages. And the obedience versus punishment stage, the individualism exchange phase, moving to level 2, where they have a little bit more conventional morality. They're starting to build interpersonal relationships, learning right versus wrong, sharing, being nice. Whereas, in level 1, it was more, well, because I said so. It was, there was not an ask why. It was just I had to do this. I don't know why. Stage 2, we're starting to develop these abilities to look at how does it make us feel. And then level 3, you've got stages 5 and 6, where you have social contract and individual rights and universal principles, where they're looking more at, how is this going to affect my group, not just me, and how does this affect the world overall. All right, so I think about it. An elderly patient is very reluctant to go to the hospital despite being very ill. And how can you address his concerns? And how do you think age differences between the patient and the AEMT could affect communication and trust? Well, if you're 20 years old attending to a person that's 75 years old, you don't have nearly the life experiences that this person has had. And if we even go back and look at Erickson's stages of psychosocial development, you could be in the intimacy and isolation phase, yet this older person is now in the integrity versus despair stage. So their big concerns are probably, will I ever return home? That continues to be a big concern in patients' minds. How can you address this? You can just be honest and upfront with them. Tell them that you're going to do everything that you can. And if you have some experiences with patients that have had similar situations, you may choose to share some of those. You've got to make sure that they understand that this is not the absolute, but also involving family and letting the family help to encourage the patient will be helpful. All right, so our life expectancy in the United States is roughly 78 years of age. It is affected by your gender, genetics, your environments, and your behaviors. And physical and physiological changes occur throughout our lifespan. We're going to identify those throughout most of the rest of this chapter. So by gender, men tend to be a little bit more risk takers. Men tend to probably not take care of themselves as well as women do. Genetics, if everybody in your family's died of a heart attack, there's probably a pretty good chance we know what you're going to die from. Environment, did you live, were you a coal miner, or did you live in the area and in the era of where there's this asbestos everywhere? Now we live in an environment that is so inundated with chemicals that much of what makes our life better, which is scientific development, is probably in many respects making our life worse. It's causing us to develop odd things like cancer. And behaviors. I mean, if you are a worrywart, you may be developing more stress in your life. However, your likelihood of dying in a car surfing accident where you're standing on top of the car as it runs down the highway at 40 miles an hour, 50 miles an hour, is probably going to be less. So obviously you have some gives and takes there. So normal vital signs for each age group. We can look at these. You can also see average heights and weights by age as listed on the chart in 217, on 217 in your textbook. Again, everything is average here. And any of us that are parents know that when we take our children in, particularly young children, into the doctors, that in many cases the doctors are going to compare their height and weight off of a norms chart and say that they're in X percentile for people of their age group. And they just continue to monitor that. And it helps them develop any trends that would maybe indicate certain developmental delays and issues. So in general, as we age, our respiratory rate, our heart rate, and our temperature go down. Temperature barely goes down. I mean, it just barely creeps down. It doesn't go much at all. Heart rate from newborn drops from roughly 180 down to 80. Respirators drop from around 30 to 60 down to 16 to 20. But the blood pressure, systolic blood pressure, tends to go up. And we've talked about how you can get a rough guesstimate of an average for a person of a certain age. So here we're going to talk neonates. And neonates, or newborns, a newborn technically is within the first couple hours of life. Neonate specifically is within the first month of life. So a neonate weighs roughly 6.6 to 7.7 pounds. All of its body systems are very immature. Humans are one of the species of animals that takes the longest to fully mature. And outside of the 40 weeks spent in utero, much of the maturity actually occurs outside the uterus, and takes another 25 years or so after a person is born to have all their body systems fully mature. There is debate on whether the drinking age should be raised to 23 or 25 years of age because there's good evidence that suggests that the brain, particularly the areas of the brain that develop certain addictions, is not fully developed until well after age 21. So there's a lot of maturity that still has to occur. In fact, the reason why infants can't walk immediately after they're born is they don't have the muscle mass, they don't have the bone strength, they don't have the neurologic coordination to do any of those things. The head is very disproportionately large to the rest of their body. If we go back and look at this picture, you can see that baby's head is getting pushed forward because it's a very large head compared to a relatively slender body. They don't have muscle and fat on them in order to make them more even. The bones are much softer. They're less well formed. I've mentioned, I know in a previous chapter, that in many cases the bones will just appear as shadows or kind of a foggy hint of a bone in a specific area until they're calcified. And that's why we drink milk for the first 20 years of life, and in many cases should continue to drink it or at least have some sort of a calcium base. And then the two major fontanelles beneath the scalp, there's actually four that form. There's two on the sides of the head that most people don't think about. They're relatively small, but you have the anterior fontanelle, which is towards the front. Basically, if you put your fingers in front of your ears and go straight up, that's where your fontanelle is going to be, your anterior fontanelle is found. There's a posterior fontanelle, which is found back on the crown of your head, back above your occipital area. So some developmental milestones during infancy. At birth, they will start to have a few reflexes. what is referred to as the Moro or the startle reflex, where a loud noise will often make them reach their hands out like they're falling and going to try to catch themselves. The grasping reflex, where if you put something, touch their palm of their hand, they're going to wrap their hand around it as a sense of safety and security. There's the rooting and the sucking reflex. You brush their cheek, they're going to start looking for something. They're going to move their head around until they try to find something which they assume to be a nipple. And then once they find that, what appears to be a nipple, or roughly that size, then they will start to suck, because that's where they know that their food is going to come from. Then in about 3 months or so, they may start to smile a little bit, start to develop a little bit of a personality. They'll try to raise their head up when they're laying on their stomach. Some of them are already getting ready to crawl. Usually that takes a few more months to get there. They can try to support their body on their arms. And they'll kick their legs and stretch out their legs. They watch for faces. They're starting to recognize people. And they're starting to be a little bit more of a little explorer. They're identifying some sounds. At 7 months or so, they're able to play. They can respond to other emotions. They're interested in mirror images, so they're looking at themselves in the mirrors. They'll struggle to get out, to get the objects that are out of their reach. They respond to their name, no. I don't know, I've got teenage children that don't respond to no. They'll babble. They'll try to roll over. Many times they'll sit and they're trying. Many of them are crawling also. At 12 months, they're shy or anxious around strangers. They're starting to develop that strong parent bond. They'll cry when they're separated from their parents. 12 months, most of them are almost walking, or at least are right on the verge there. Most of them can say mama, dada, and a few other smaller words. They're starting to eat more solid foods and may be capable of helping themselves. That can occur a lot earlier as well. Start to use objects and start to be a little bit more familiar with some of these things and how they are appropriately used. Can start to grasp things, bang objects together. By 24 months, they're excited about other kids. They start to have loving, caring relationships, trying to be more independent, like taking off their diapers and running around. Starting to use more imagination and have a fairly broadened basic vocabulary. And then by 3 years of age, there's a lot of good play and learning that goes on there. They're starting to be able to do things a little bit more refined, and their language skills are jumping up expeditiously. So here we have a little infant. Ain't she cute? So neonates and infants have a greater surface area to volume ratio. Basically saying there's a lot of skin compared to bones and muscles when it comes to kids, or when it comes to neonates and infants. We have lots and lots of surface area. Therefore, they get cold quick, as well as they potentially can get burned easily. And a small burn is much more dramatic on these little ones. Their immune systems are pretty immature. Initially, most of their immune system comes from their mother. Some of it they were born with, some of it they can get from breast milk. Whereas this is really the phase starting around age, they'll get shots throughout the first year, but that first 6 to 12 months is when we really start to hammer them with lots of immunizations up through the next couple of years. They have fewer alveoli in their lungs. Their lungs are still fragile, particularly the earlier in life they are. Respiratory problems remains their number one potential problem. and they very quickly go into a respiratory failure and respiratory arrest. Kids will do a pretty good job of hanging on, but once they're done, they're done. They crash. For the most part, adults, we can kind of trend them going down. Sometimes in kids, they go from doing very well to not doing at all. They can develop things such as excessive dehydration from nausea, vomiting, diarrheas, not drinking, not eating. Those sorts of things can become causes of shock, actually, very quickly in their life. So they're getting their immunizations, like I mentioned. And a crying newborn, an infant, is really its only way of communicating. They don't have the language skills to say, hey, I'm cold, hey, I'm hot, help me, that hurts, I'm hungry. So then we move on to the toddler stage, also known as the terrible twos, or threes, or fours, or teens, and the preschoolers. So toddlers is generally age 1 to 3, and preschoolers 3 to 6. Toddlers are slowly advancing their social mechanisms there. We kind of touched on some of those in their developmental milestones chart from earlier. Their head is starting to match their body because now they're able to walk, they're able to do more physical activity, so they're going to start to build a little bit more muscle. They're usually eating us out of house and home, so they're putting on some weight. And toddlers are very, very curious. One of the more common age groups for us to run into poisonings. Not that it doesn't happen in preschoolers, but toddlers still just don't have that sense of right and wrong and that sense of danger quite yet. Preschoolers, their head is still fairly proportionately large, but again, like I said, they're growing into it. They're very social now. This is the age group when kids say some things that makes their parents pretty stinking embarrassed. Ear infections and respiratory tract infections are very common. They affect many kids each year, and sometimes kids get them every year. So kids are ending up with tubes quite frequently. One of the big problems that causes ear infections in preschoolers and toddlers, and Indian babies for that matter, is in the adult, our ear canals go from their highest point being our ears down towards our nose. In fact, they do drain into your nose. There's an equalization chamber, it's called the eustachian tube, that actually helps you to equalize pressures. But anybody who's ever blown their nose and had their ears fill up at the same time, you can thank your eustachian tubes. But the drainage system, if you will, an equalization system, for an adult goes from the high being your ears and the low being where they hook into your nose, whereas with an infant and small children, that drainage is actually more flat. It's a horizontal tube as opposed to a gently slanting tube down towards your nose. So that's where a lot of ear infections come from, is that it doesn't drain, it just sits there, stagnates. Hopefully by the time they're in preschool, we're talking about being toilet trained. Not that they're not going to have the occasional accident, but toilet training is very common in the preschool age group. And language skills and vocabulary continues to develop. Granted, they can't generally hold a long, in-depth conversation, but they're starting to build those abilities. When we move to the school-age children, the school-age children are ages 6 through 12, or really up until about the time they hit puberty. And the school-age children, they're physically proportionate now. Their heads may still be slightly larger, but for the most part, their body fits them. They're starting to develop relationships outside the family, so they have their friends at school. maybe their friends in the neighborhood. They're developing their self-esteem, and it's a primary age in which it's very important that self-esteem is supported in these kids, because it can make it very difficult for them to move on through life if they don't have that self-esteem. They feel like they're unwanted. They're developing their own identity. Sometimes it's an identity that they think that their parents and their loved ones want them to have. And they're starting to develop that modesty and that need for privacy and to do their own things. Then we have adolescence, which is the hell known as their teenage years. This is the age groups basically 12 through, they'll say 18, but again, that's generally open to debate. In some states they'll say 19, some places say 21. There are states that are now starting to enact rules that they will not sell cigarettes and tobacco products to anybody under the age of 21. So again, goes to support that. There's not a nice line in the sand. So physical growth is nearly complete. Their puberty, they're really starting to develop fully their secondary sexual characteristics. Most likely early on in this, towards 10, 11, 12 years of age, girls will have their menarche, which is their first menstrual period. That tends to be earlier in girls. Boys start to grow a little later. So the interest in the opposite sex and romantic relationships can obviously starts here. Very awkward age for children to be in. Their adult judgment is not completely developed. They still engage in a lot of risky behaviors. Generally, kids believe that they are invincible and sterile, and that obviously rears its ugly head every once in a while when we either have a child dying from doing something stupid, or middle school girls that are pregnant. They become self-conscious and very concerned with their appearance and their body image, and obviously spend a lot of time on that sort of thing, and are very, very important to them. We have the young adulthood. Young adulthood is generally aged around 19 to 40. That's when people are in their peak physical condition. Their leading cause of death is trauma, and romantic relationships are developing, and real intimate relationships can actually occur here. It's often when many young people start to develop and start to have their families, and there can be very high stress in their jobs and in their education as they're starting to develop a career. Whoops. Back up here. Middle adulthood is generally 41 to 60. Age-related changes are starting to come about. Vision is decreasing, hearing is decreasing, metabolism isn't quite what it used to be, so people tend to put on a little weight. Cardiovascular disease starts to spike. Women are going to enter menopause when they will no longer be generally fertile. There can be certain financial pressures here. This is also the age group which gets referred to as the sandwich generation, in which they're stuck in between trying to finish raising their children and getting ready to, if not already, having to take care of their parents as they age. There's something I've heard said about the age of 40, hitting the age of 40. Before the age of 40, you're likely to die from doing something stupid today. After the age of 40, you're likely to die from the stupid stuff you did 20 years ago. So I think that is kind of poignant, because all those 20 years of eating hamburgers and French fries, and now we're having to deal with the atherosclerosis, heart attacks, and overweight and whatnot that comes with that, as well as potentially diabetes. And then we have our older adult group, late adulthood from 61 on. Their body systems are in a significant decline, respiratory, cardiovascular, and kidneys. Also, we can take musculoskeletal and throw in there because osteoporosis becomes a big issue, particularly in the females. Pain perception decreases, so they may not fully comprehend the discomfort that they're truly in. Cognitive decline, where they're kind of starting to lose many of their faculties. And the view of the aged varies by culture. Some of our cultures feel that once you've hit retirement, you're really not of much use anymore, where others tend to look at them as these are the wisest and the leaders in our communities, and those are the ones that should be revered. So this chart kind of just goes on to talk about a few of the potential physiologic changes associated with aging. I really don't need to read these to you. They're in your text on pages 224. I honestly don't think anything is going to be earth-shattering in here, but some things that we probably don't really think about much. Things like the skin, becomes thin and becomes fragile. The gastrointestinal system just doesn't work quite as well. Constipation's an issue. I mean, there's two major events that occur in a nursing home every day in a person that resides there's life. Number one, did they have a poop? And number two, did they have a nap? That's their two biggest concerns in the nursing home in many cases. Sad but true. All right. Okay, so culturally, things that you take for granted often can be not taken quite as well by other cultures. Certain biases and stereotypes, lack of understanding, leads to some disparities, and often we're disrespectful, and we don't respect our elders or other people, other cultures and populations. So let's hit on a couple of those cultural differences. People often will take a more holistic view on their health and medicine. Here we are, medical providers. We're in the field of medicine, and we tend to believe mostly in modern medicine, where there are a lot of people in this world who look at it more beyond modern medicine. The holistic view of things such as do we need to involve religion, herbal medicines, chiropractic, acupuncture. So there's a lot of other things that people believe in. That it's not just the modern medicine, which is what we practice. Same-sex healthcare providers occasionally. Interestingly enough, there are certain places within, say, New York that there are community ambulances still. It's not that the entire city of New York has just the FDNY, but there's a lot of communal ambulances there, particularly in the certain Jewish faiths up there. And so they will call their local community ambulance, and only females can take care of females, and only males can take care of males. And so it's kind of become an issue that they sometimes get into a crunch with personnel. The importance of prayer. We're all over the place with this because we're generally so receiving and so receptive to people practicing their own religions that we lose sight of how many different beliefs there are in religion out there. So depending on the person, I mean, there's certainly those people who are on the perspective of being agnostic and believe that there is nothing, atheists, that there is nothing that is a higher power. There are those that say I don't have enough information to make a decision one way or another, and then there are those that are very staunch their belief that there is only this way. So we have to keep that in mind. And generally, if we're working in smaller communities, we have a pretty good feel for what sorts of religious backgrounds we may have. So the Hispanic population, the Latinos, there are almost 47 million Hispanics in the United States, roughly 15% of the U.S. population. I wonder if that's maybe a low number. African Americans comprise 13.5% of the U.S. population. And then there are 562 federally recognized American Indian and Native Alaskan tribes in the United States. So even in, particularly in Nebraska, we have several Indian reservations. I believe offhand there are 5, but federally recognized Indian reservations here. So they're going to have their own cultural issues that they potentially are going to come across. So when we look at a couple of these groups, we can identify a few commonalities. Hispanics tend to have higher rates of obesity and diabetes. Cardiovascular disease comes along with that. The Hispanic population, eye contact is important. Physical contact is important. Family is enormous. So everything is around the family. So in many cases, there's many people living in a house, and it may be 3 generations of people living in that house. The African American populations tends to have a lot of economic and educational disparities. Unfortunately, many of them have gotten caught in the rut that they can't move past some of their culture's past. We don't, and it's sad to say, many times they pigeonhole themselves, or certainly we still pigeonhole them. So they tend to have some distrust of healthcare and of authority, of course. Can be the same thing with the Hispanic populations. They don't fully trust the authority, or the Hispanic populations usually have the issue with language. They don't understand the language, so therefore can't fully take advantage of it. And in the African American populations, hypertension, which leads to cardiovascular and stroke issues, remains very big. Renal failure is huge. Lung cancer is big. Diabetes, also very common in the African American population. Sickle cell crises or sickle cell disease, very common in this group. 8% of people have the sickle cell trait, and 0.2% have the sickle cell disease. It's nearly exclusive to the African American populations, although a few other ethnic groups may occasionally have some issues with sickle cell. When we're talking about Native Americans, the disparities of access to health care and poverty that is commonly seen in the Native American populations is incredible. There's often not appropriate care, and there's a general, again, distrust of the modern American society. Alcoholism, tuberculosis are huge. Diabetes can be very big. Their suicide is enormous, and a high infant mortality rate. A lot of them live on reservations or very near to reservations. They hold family and their religion and tribe very high, very high in their grand scheme of things. So they tend to be more holistic in their treatment and rely just as much on their medicine man, who is really more of a holy man, than a true medical scientist, and so they'll use sometimes combinations of both. Extended eye contact can be an issue. They can see that as kind of being threatening. And then understand that sometimes we can have an impedance in our vocal communication, simply for the fact that they may speak the native tongue. The Asian culture, in the Asian cultures and the Pacific Islanders, very diverse group. They come from an enormous area, although much of it is separated by waters. But there's hundreds of languages that they speak. Some of them are actually American dependents, based off of the Pacific Islands that they're in. There is a large number of Asians on the coasts. Like I mentioned, occasionally we find a spot here around the Midwest that Asians become kind of flock to a little bit. Obesity, stroke, and heart disease tend to be lower amongst them because they're generally healthier, and they have some of the longest life expectancies. Their dietary habits are impeccable compared to the common American diet. Lots of low fat and low red meats. They have a lot of respect and family loyalties. A lot of times, though, they do repress a lot of their emotions, so they don't often act out or act negatively. A lot of times they're very, very polite people. They also use a lot of holistic medicine and traditional medicines. And then we also have the Middle Eastern cultures. Islam is the most common religion for the people in Western Asia and the Middle East, if not one of the most common in the world, pretty close. The people of the various religions will have varying views on culture and heritage, so it's very hard to specifically pinpoint things there unless knowing where this person's coming from. Remember that people, the original Jews come from the Middle East, and pork in many of the religions of the Middle East, not just Judaism, but as well the Islam is considered a no-no. Jewish have to have very strict health or very strict food requirements. They have to be kosher. And in a lot of the Middle Eastern, say, Arabian areas, women are covered. Much of them are covered. And I've dealt with cases in which we've had to transport women, and all you could see of the woman was her eyes. Everything else was covered. And then Muslims pray on a very regular basis. So you're in the home of an elderly woman from an Asian country. She doesn't speak English. Her young grandson places a call for 911 and is attempting to translate. What other resources do you have to conduct your assessment and communicate with your patient? Well, do we have anybody else around that can help us? Do we know of anybody who is of an Asian culture that we could get in contact with to assist us with this? We don't always have all the resources at our fingertips in the ambulance, but in many cases the hospitals have lists and services that they can use to assist in communicating and assessing. Grief, death, and dying. People can die at any age. Obviously, something that we become very accustomed to very quickly in our profession here. And it can be very difficult. It's difficult for us as providers. It's difficult for the family members. It's difficult for the person who knows they're dying. So as we suffer losses and deaths of loved one, they slowly take their toll on us. Obviously, they tend to be the most painful immediately following or leading up to and away from the event, but they tend to have we tend to have these affect us for long periods of time. So bereavement is the state of experiencing a loss. Grief is that emotional reaction to that, and then mourning is the expression of that grief. So they're really interconnected, obviously. So Elizabeth Kubler-Ross's 5 stages of death and dying. You guys, I hope, have seen this before. I might see if I can find a little video to post on the course page that has to do with this. It's kind of interesting to watch. But so Elizabeth Kubler-Ross had, she was a psychologist that really started to identify with certain characteristics she saw in patients that were dying, or for that matter, their family members were dying. And those stages were, I like to remember them by saying DABDA, D-A-B-D-A. First is denial, second is anger, third is bargaining, fourth is depression, and fifth is acceptance. So denial is somebody, oh no, this can't be happening. This isn't happening. I don't believe it. The anger is now a hostility against really it's the process and the disease and or the injury that creates a lot of anger amongst either the patient or the family members, and so sometimes we have to deal with that when we show up. We have family members that are, oh no, it can't be. I don't believe that it's happened. Or we have family members that are just furious and they're angry and they're mean and they're taking it out on us. We can move towards bargaining. Bargaining is that family member or the patient making promises, saying, oh, please let me live to see my daughter get married or my son graduate from high school. They may be trying to take vows to become a better person. They may have a depression, which is a sadness. They a lot of times will become kind of withdrawn. And then finally there's an acceptance, in which if the dying person has enough time, eventually they accept that this is the way it is. This is what's going to happen, and there's no use in crying over it because it's going to happen. Not necessarily liking it, but they get it. People do not always follow the same path. People do not always go from one stage to another. Sometimes they're in multiple stages. Sometimes they bounce back and forth. So it can certainly be a dynamic process of accepting death and dying. All right, so before the age of 6, children do not understand the permanence of death. Often it's the death of a pet as that child's first introduction into that death process. A lot of times they think very magically about it, and it doesn't even really hit them. And they may have to keep coming back to that, well, when's so-and-so coming home? They can react to death by becoming very anxious, the separation from their loved one, and they can obviously have those feelings of abandonment, insecurities, and fear. Children can have nightmares that go along with the death and dying process. Crying a lot of times comes with this, but that may actually be as a result to seeing what everybody else around them is doing. They may not truly understand. And sometimes it actually makes them very distrustful of the healthcare provider. So the ambulance shows up, hauled away their grandma, and grandma never came home. And now grandpa's sick. So are they going to develop a mistrust of EMS because, well, they took grandma away and she never came home? Different cultures have different rituals surrounding death. They're generally very heavily influenced by religious belief. That's when people tend to get the most religious, is births, deaths, and weddings. become the most religious. So just a couple of general observations to go along with this. Hinduism. Hindus, they strive to achieve freedom from eternal reincarnation that result from karma. So they believe that the life basically you live now will influence what you become later. So they may try to take care of any unfinished business. Judaism. The Judaism, with the various different branches of the Jewish faith, they tend to have a period of mourning that is referred to as Shiva, and it extends from death until 7 days after burial. And in many cases, they'll sit very low on the benches or on the floor during Shiva. One of the things that Jews commonly believe is that a person should be buried within 24 hours, but not done on the Sabbath. That's generally what, remember, Sabbath for the Jewish faith is Friday night into Saturday, I should say. And so that's some of their beliefs. The Hindus a lot of times will look at chanting and meditation, incense. Pictures tend to be turned away, turned to the wall. So in the Hindu faith, organ donation, I believe in the Jewish faith is acceptable with the rabbi's approval. Some faiths really have taken a very staunch stance against this, including the Hindus. They will not allow for organ donation. The Buddhists have a lot of variation in what they have. They also believe in karma and the rebirth, and are hoping for some freedom. Buddhists believe that separation and suffering, such as birth, illness, and death, are inevitable, and that the suffering results from the desire or the attachment. So they'll have various steps that they take to eliminate their suffering. They're hoping to lead to nirvana, which is basically their ultimate paradise. They're very specific about how the body should be handled, and autopsy or organ donation may or may not be allowed by the Buddhists. Islam, the Quran, it does not give very strict guidance on a lot of these matters. So a lot of times it results in just a lot of prayer, and there's cleansing rituals. They face towards Mecca, which is generally to the east, at least in the United States. They have very strict dietary requirements, and it is preferred that they have a same-sex healthcare provider. But at death, the patient should be turned face towards Mecca, and after death, the body shouldn't be touched by non-Muslims. So autopsy is allowed only if it's required by law and organ donation possibility. Now, Christianity, probably the one that most of us are familiar with. Most Christians believe that Jesus Christ is the Son of God, and that there is an everlasting life after death. Most Christian sects will allow organ donation, and depending on the sect, there may or may not allow for there to be cremation. And a few areas don't want any specific medical procedures done, like blood transfusions and whatnot. So the reaction to death is going to vary based off of whether you have a very progressive or liberal Christian sect, or if it's more of a restrictive and conservative sect. So in many cases, it's just it's so all over the place. Whether it's people are being embalmed, some people are not embalmed, depending on the various other rules of the religion on how the body is handled and funerals occur. So if we have a death in the field, once the patient's died, the well-being of the family becomes the AEMT's priority. If there's nothing we can do, then there's nothing we should be doing. There are people that will discuss, well, if we can do something, we should do something. Well, you have an ethical dilemma. We'll take, for example, a SIDS case. Well, if we show up on a call and there's a baby that is found dead in their crib, and they are obviously dead, dependent lividity, and they're starting to develop rigor mortis, there are people who will say, well, we should do everything we can for this baby. Well, the argument to that is, if we know this baby is dead, why should we do that? There are people who say we should do basic things for this baby to make the family believe that we're doing everything we can for the baby. But in that case, we're instilling false hope, and we, again, are doing stuff that is not leading up to the fullest of our abilities. So there's an ethical dilemma there. And then there are those that say, no, we do nothing, the baby's dead, let's leave the baby here. And in those cases, are we doing the family justice? So we get kind of into this big quandary on what truly is the right way to go. And I think a lot of it then is going to fall onto you in the situation that you fall into. The fact of the matter is, if the baby is dead, the baby is dead, and there's nothing we're going to do to change it. So we focus on the family members. We can try to be as helpful to the family as possible. If we can make phone calls, sometimes it may be appropriate for us to allow them to go in and view the body. If it's a baby, hold the child or hold the baby. Keep in mind, though, if there's suspect about the death, we also have to involve law enforcement and either contact our medical examiner or coroner, depending on where you live. You probably have a very specific protocol about who to call and what to do. Hospice is a concept that's fairly new to the grand scheme of healthcare, and hospice is really dying with dignity. So it's assisting terminally ill people and their family members for the patient's death. So it's basically, they said, we're withdrawing most of the treatments. We're going to keep them comfortable. We're going to allow them to live out their days in comfort and prepare for the inevitable. Palliative care, a lot of times, is part of hospice, and palliative care is making that patient comfortable. Might be a little oxygen, maybe occasionally some IV fluids because they're a little dehydrated, but a few medications just for comfort measures. They're not getting things like chemotherapy, and in many cases they're not taking all of their therapeutic medications. It's just making them comfortable for the remainder of their life. All right, so hopefully we've gained an understanding of cognitive and psychosocial, physical characteristics of our different patient demographics. Understanding that people have different fears and concerns depending on their age and their backgrounds. We've identified a few things amongst children that work a little differently than they do in adults. We're by no means done with it. We'll revisit it when we get to pediatrics. Elderly are less able to compensate for many of their illnesses or injuries. And then we have a lot of cultural and ethnic issues that potentially can arise in healthcare. Cardiovascular disease, cancer, and stroke are leading causes of death in the United States, period. An attitude of seeking understanding is important. I'm fairly sheltered and fairly limited in my knowledge of many of the other cultures out there, but I try to make it a point that if I come across somebody that has a different background, that I talk to them and I find out more. And it's that thirst for knowledge that will build you as a person and a provider.